Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started.
Welcome back, ladies and gentlemen, to Healthcare Reform 2.0. This is Season 2, Episode 2, A Predatory and Hostile Economic Healthcare Environment. I am, as normal, joined by my partner in crime, Tim Henning. As we talked about in the last episode, I got a new house, smaller house, one story for old people. And because I want to make sure Tim is well taken care of, I moved close to him so he can come over to our one story and hang out.
I can actually walk over, but he turned the fireplace off because it got too hot.
Yeah. It's we had the fireplace running for the last show, and we turned it off for this one. We're recording a couple of shows back to back, and we're going to be pushing these out at 15 to 20 minutes a show instead of 45 to 60 minutes a show, because that's one of the comments we got back from you guys. So without any further ado, Tim, why don't you go ahead and start to talk about what we're going to talk about?
Yeah, as we closed out the last episode, we talked about the theme for Season 2, dangerous, hostile, and predatory, inside the American Healthcare Quagmire.
Right.
So today we're going to focus on predatory and hostile. When I first heard these words, a predatory and hostile economic environment, I thought I understood just what it meant. It wasn't until after being on the provider side of the business, meeting you, reading your book and others, and working with you here on Healthcare Reform 2.0, did I really get these words really sink in. And so I learned a lot, and I wanted to start with having the conversation about some of the things that go on within healthcare, especially on the predatory side of the business, because it's highly predatory. I don't think most people realize that until you don't live in those shoes. You walk in those moccasins, and it's a completely different environment.
Oh, yeah.
So the scramble for healthcare dollars has proven extraordinarily expensive, both in terms of quality of care, which is very important, quality and cost. Mm-hmm. We're not just talking about cost. Again, from Maggie Marr's Money-Driven Business. The result is a marketplace where a war of all against all pits the healthcare industry's players against one another. Hospital versus hospital, doctor versus doctor, doctor versus insurer, insurer versus a hospital, insurer versus insurer, insurer versus drug maker versus drug maker. In this adversarial environment, competitors do not create value. They divide, and sometimes they destroy it. Tom, you and I know just how real the above statements are. Can you please expand on your experience, research, and the time you worked on Capitol Hill and your work on the ACA around this topic, and just how hostile is this economic environment?
Well, Tim, it's a great point. And like I said in the last episode, this current thing that we have got its roots back in the 1950s in the rise of what then was indemnity insurance, the way you and I remember growing up, where you had your family took you to a general practitioner. He got paid by your insurance company for a subset of things that he did for you when you were sick.
Yes.
You paid for your visit to the doctor. But if you had appendicitis, then insurance would kick in and pay for some, in few cases all, but mostly some part of that. And the primary reason for indemnity insurance was to protect you and your family primarily from losing your house.
Right. Catastrophic.
That was what it was for. It was catastrophic coverage, and it was there. And you have to remember, in the 1950s and 1960s, we weren't living as long as we are today. We died a little bit younger, which saves a lot of money because, as we've said many times, the older we get past 45, the more the cost of care starts to ratchet up. It's an exponential curve. Yeah. So it's from that we got into the era of the HMO. And when we moved into HMOs, the relationship between insurance companies and hospitals and doctors shifted. They started to take the prices they were paying before, the insurance company, they started to take the price they were paying before and negotiate off the list price as a discount for the services they were paying for that you, the provider, were providing. And the initial discounts were, we're going to pay you 80% of what you normally charge. We're going to pay you 70% of what you normally charge. By the time I was working in looking at hospital systems and helping a children's hospital, the average reimbursement rate for most of the procedures we were getting paid by insurance was 25% of the list price. So if it was $100 charge, $25 was getting paid. Now, we knew at this hospital that we had to renegotiate our agreements in the upcoming year. So I led a team to do the analysis. And what was the analysis for? To figure out how to do it cheaper? No. The analysis was to figure out what I needed to charge in order to get paid the same amount of money.
And that's why everything's going up year on year.
Exactly. And that's one of a number of things. But in the predatory world, the insurance company was preying on the providers in the hospitals. Hospitals were getting hit harder. And then as PPOs came up, hospitals got hit even worse. So hospitals started negotiating with HMOs and doctor groups to pay them discounts on services that they aggregated through the hospital. And hospitals were trying to negotiate with the insurance companies, but they didn't have as much leverage with the insurer. So insurers were then preying on the hospitals and preying on the doctors to make more money in insurance by taking money out of the pockets of the providers and insurers. Now, as things started to grow and hospitals got larger and aggregation took place, there became a little bit of parity in the system. But then, as you said earlier, the drug companies are preying on the doctors and the doctors are preying on the hospitals and the hospitals. Everybody now is always negotiating against everybody else for a way to get a few shekels in the door in order to make any money at healthcare.
Right. It's a free-for-all.
Exactly.
And the providers are wrestling for scarce healthcare dollars.
And the current system has exacerbated this because the idea of an accountable care organization comes down to outcomes and management of outcomes. And the problem is not all populations of people are easy to manage. In fact, some are impossible to manage. So hospitals that dealt mostly with the indigent and the underserved really got in a position at the beginning of this current healthcare system that they couldn't keep doing 90 or 100% homeless and indigent care. They couldn't get paid because they couldn't improve the outcomes, and the people kept getting readmitted and they were going to get penalized for the readmits. So they started shifting their mix and pushing some of the undesirable patient population that they couldn't manage and increase the population of the patients that they could manage. So it shifted the care to the indigent off to other areas and other people, which has increased the cost and decreased the quality of care that the indigent population or the underserved population are getting.
And access.
Exactly. The other thing that's happened is as we've pushed down this path, the predation isn't just happening around money. It's happening around risky cases. Some hospitals that are taking people in the ER are diagnosing them, finding out that they have something that has a horrible reimbursement rate or no reimbursement rate, and in cases, pushing them out back into the street, or in some cases, hiring transport companies to take them to the emergency room at another hospital.
By the way, that's a violation of law, but it's still happening.
It is happening. And I've heard it happening more and more as time's going on. Now, we want to blame the doctors and we want to blame the hospitals, or we want to blame in the provider side, they want to blame the patient. Or we want to blame the government or the insurer or the drug company. The reality is it's all of those things and us too. We're the ones that have built this mess. We're the ones that have demanded things from people they can't provide. And then when they can't provide them, we either want to sue them or we want them to pay for it. But we've got to get to where we rationalize all this stuff, because we truly have built a system where everybody is out for everybody else. But the two things that aren't connected is the patient on the one side that needs the care and the payment for the care provided on the other. The patient is nothing but chattel to help those people negotiate all the stuff over here. Why? Because most patients can't or won't take an active role in their care.
And the predictable result is a fragmented, inefficient, and expensive system.
Exactly.
It all adds up.
Exactly.
Yeah, I see this all the time, especially on the provider side, where providers will push into a market and do exactly as you say. They want to go after the more favorable, higher private pay patients. So exactly what's happening in the rural communities. We're losing doctors, we're losing specialties.
And hospitals.
Right. So we see more and more of that, and it goes on and on and on.
Yep.
To add to that, and again, part of this occurred when, in the mid-'60s, when our President Johnson and Wilbur Mills had a famous phone call, and Medicare was born.
Exactly.
So we funneled more money into the system, and the medical arms race began. We put MRIs on every corner. There's a Starbucks, there's an MRI. We got to have a Da Vinci in every account, and it has to be right next to each other because I have a market advantage over you, because I'm predatory and you've got a Da Vinci, so I want one.
And just for the people that may not know, a Da Vinci is a robot surgical device. Very, very expensive. And of marginal benefit in some procedures that are very common.
Exactly. So we developed this, I can get it because it's going to be paid for. And we added more supply into the system and the demand went up.
Right.
Opposite of what it should be. The other piece that is striking, and we've read an article about this, is the hospital systems that think bigger is better. And we constantly see this. You're going to see the new merger between I think it's CHI and Dignity and a few others.
Right.
If you take a look at what happened in Providence, I've seen no improvement in any type of integration.
And the most important thing is they're trying to do this because they're trying to figure out a way to get margin back in the system.
Yep.
They figure, well, we'll find a way to aggregate and lower cost. Bringing in doctors has traditionally been costing the hospital about $160,000 to $170,000 in aggregating their practice per physician brought in, not making them money, losing an additional $170,000, $180,000. So they've gone around and laid off a number of physicians that were redundant, they didn't need, or weren't very good producers. So we're in an environment where we complain we don't have enough physicians, and that with all this stuff going on, we need more docs. But then hospitals and large provider groups are laying off physicians who now have to go back and start up again. And where do they go? They don't go into specialty practice because that requires you be part of a hospital. So some of them change their practice models and either become a general practitioner, or lo and behold, they show up as retail medical spas.
Or they end up, being plastic surgeons. And then the other issue is the systems predatorily buying up physicians groups. Mm-hmm. Now, you would think that would be a really cool thing and everyone would be just really happy about that. It's quite the opposite. They put so much pressure on these physicians, denying them access, that they almost just become overwhelmed and cave in. And part of that's because of all the regulatory issues we put on top of physicians.
Yep.
So you go to the system, let them deal with it. And you end up at the Sutter. If you're in a corporate practice medicine estate like California, you have to go to a foundation. Some states you can hire docs. And what happens when you get hired, Tom?
When you get hired, you lose all control over your practice.
Yeah, but what could happen?
What could happen?
You could get fired.
Get fired, yeah.
Exactly.
Yeah, and
that has happened time and time again.
Oh, yeah. And they're not getting fired because they're bad doctors. No. And in fact, there are people out there today that are arguing that some of the doctors that are surviving are not the best and the brightest of the group. They just happen to be the ones that have figured out how to play the game the best. Sounds a lot like other professions, doesn't it?
Very much. So we've seen a little shift in specialty hospitals versus community hospitals. There's been some regulation against this to some extent. That one really pits, if it's a specialty hospital, many were owned by physicians. People tried to put a stop to that. Some of the legislations had been passed against that.
But it hadn't done much.
It hasn't done much, really. Right. Especially with surgical care centers, which are notorious for taking people out of the network.
Yeah.
Notorious for it.
You know, on the out of the network thing, we're going to do a show, Tim, on hospital solutions to the surprise of out of network bills. And the article is titled "Make Physicians Go In Network." Now, if you read the title, you think, oh, they're going to hire more physicians to work in their network. No, what they're doing is taking the physicians in their network and saying, if the sub that you're trying to go to is not in our network, you cannot refer the patient to them.
Right.
And that sounds to some people like, well, that's a good idea because it's going to lower cost. But the reality is, even at Kaiser, which is one of the most vertically integrated medical systems on the planet, they have to refer out to specialists at Stanford and a number of other organizations to take care of critically ill patients with something more than a rudimentary need. And that's not to say Kaiser doesn't have a series of specialties as well. They do. But there's no medical system on the planet that is a specialist at everything.
Which brings up the comment that was made by, I think, one of the astronauts, is that I'm just really comfortable in the fact that what I'm flying is and was given to the lowest bidder.
Exactly.
So, I mean, that's one of the things you have to be aware of.
You've been listening to Health Reform 2.0 with your hosts, Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit, and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.